Thank you, Dean. We started about 15 minutes late because of the snow this morning, so why don't we take 10 minutes for questions? And so open the floor to questions.
No, I was going to ask Julia and Kathy, if you were going to ask a group like this, what could they do to help you most to move forward effectively in translation and coming to scale? What would you ask us to do?
Elizabeth, I think that's quite a big question. Because I think what's going through my head is almost all the stages that Brian and Dean have been talking about. It's about convincing politicians. It's about having enough money to test things. It's a whole set of things. So so I'm not going to give you a very clear answer because I've got all this stuff swirling in my head at the moment. But I do think that it may be about working with politicians to understand the value of evidence-based science, and then also with funders to fund it. Because I think that's one of the big barriers that we face in South Africa is the funding. So yeah, I think that would be my two answers.
I think that equation with the successful outcomes, somehow we have to get that across. And we have to get it across to just those groups, the policymakers and the potential funders. Does this group lobby for that kind of information sharing? If so, then I would say that's where I would like it to go.
Jacqueline, did you have a question?
Thank all the presenters for your presentations. I thought they were very interesting and informative. I have a question for Brian. So we've been talking about politicians and the importance of communicating data and evidence to politicians, and you had some success with the governor who closed the juvenile corrections facilities and put the money towards evidence-based programming. Could you speak to what you think were some of the key strategies or the key factors that influenced that decision?
Right, so I very briefly put up and very briefly described that Venn diagram, and it's really about that. If you think about, how we typically go into this is we go to some audience and we say, well, we've discovered programs that reduce violence, or we've discovered programs that prevent youth drug use, and we assume that our audience cares about those things and cares so much about those things to move them to the top of their Maslow's hierarchy of need. So instead, we go to these audiences before we have anything to sell, ideas or otherwise. We first develop relationships. We go to these audiences, policymakers, practitioners, researchers, and say, what are your goals? What are you judged on? What are your performance measures? And then we work to help them achieve those things in ways that also meet some of the goals of population level health improvement. So for the governor, to be very specific, the governor was facing a crisis of corrections population and spending. I'll share some bad news about Pennsylvania. I shared all the good news about Pennsylvania. In Pennsylvania, we've got over 50,000 state prison inmates and a state corrections budget near $2 billion a year. That's $5 million a day Pennsylvania taxpayers are spending just housing and feeding state prison inmates with no outcomes to show what we get for that. In fact, there's lots of research to show that we've turned the curve on the effectiveness of incarceration about 40 years ago. So we knew that it was important to the governor to talk about cost savings and to talk about solutions to addressing this prison population crisis. So we framed it in that way. It was about, how do we reduce costs? How do we reduce the impact of corrections in the state budget? And how do we do it in ways where we have lots of data to show that this is an effective investment? So part of it was getting him to, you know, to shut down that juvenile correctional facility. But the other big challenge was then getting him to dedicate that cost savings, not to fixing roads or balancing the budget, but to supporting the very programs that we think are responsible for driving down those costs.
Thank you, panel. Brian, one of your slides really struck me about different factors contributing to both the intervening factors, also the outcomes. You know, I'm a geriatrician, and much of the geriatric principles, when we think about geriatric syndromes, things like dementia, delirium, fall, decubitus ulcerae, incontinence, they all have multiple factors leading to one outcome that are not necessarily fits tightly into what we call the clinical diagnosis of a disease, but rather multiple disease triggering to something. And what has worked well in the field of aging is what we call really multi-component interventions. It's really focusing on multiple components, not just necessarily a risk factor that's being studied through that RCT or the other design, but really take a collective of risk factors. Now, there are pros and cons to it. The pro is certainly that you work on multiple facets. You hope to capture not only one or more of those risk factors in terms of violence prevention outcomes, but understanding interconnectedness among those risk factors. The downside is certainly is we don't know exactly which component intervention that did the outcome good or bad in that way. Perhaps you can postulate a little bit, how would the multi-component intervention work, whether it's for intimate partner violence or in our world, elder abuse scenarios itself, and how would that, you know, comparing to the RCT design, which would be, I mean, conducting RCT on multi-component intervention is doable, but it's a lot more messy than a single point of entry.
Well, you know, again, we're approaching this from a community level, population level, public health perspective. So think of the community as the patient, and we're not looking for the intervention that's going to improve the health of the community. We recognize that every community has lots of things going on. In any community, there are multiple interventions, and you can think of those multiple interventions as components of a multi-component community level intervention. The intervention is everything that's going on in that community. This approach of data-driven decision making at the community level about what are the most prevalent risk factors and least prevalent protective factors. It's an imperfect science at best. It's not the precision of that instrument, if you will, in diagnosing the problem of the community is imprecise. But compared to the counterfactual, compared to the way communities typically decide what programs and services to implement, to adopt or implement, or continue, it's a giant leap forward. And so the process of even introducing etiological data and the concept of risk and protective factors and the idea and facilitating the idea of data-driven decision making, that process itself, regardless of the precision of the tool, the process itself ends up creating much more sophisticated thinkers and decision makers and practitioners at the community level, which we think has a spillover effect and is part of what leads to improvements that we can measure with intent to treat designs that aren't looking at who got better for going through a specific program.
I don't think we have time for any more questions. We really have to move on, but I just want to thank the panel. Each of the presentations was superb. It's almost like we planned this panel. So thank you very much.